Thank you very much, Rochelle. Hello, everyone. I'm Mandana Khalili, a professor of medicine and director of the UCSF Research Coordinating Center's Investigator Development Unit of the NIMHD Health Excellence Action Network. I'd like to welcome you to our monthly training webinar. Today, we are honored to have Dr. Keith Chan speak to us on translating research findings to lay populations. Dr. Keith Chan is a social worker, scholar, and educator, and an associate professor at the Silberman School of Social Work at Hunter College. His research focuses on Asian Americans, immigrants, and older populations, as well as the impact of opioid epidemic across the lifespan. He currently serves as a co-investigator of the Rutgers-NYU Center for Asian Health Promotion and Excellence, and as well as the Resource Center for Alzheimer's and Dementia Research in Asian and Pacific Americans. Dr. Chan's social work practice experience is primarily with persons diagnosed with serious mental illness within minority and immigrant populations. And since 2018, he's been appointed by the Office of the Governor of New York to serve as the council member of the New York State Interagency Geriatric Mental Health and Chemical Dependence Planning Council. At Hunter's College, he currently serves as the chair of the Social Welfare Policy and teaches social work research and clinical practice with older adults. Thank you so much, Dr. Chan, in joining us today, and we really look forward to your presentations. Before we start, I just wanted to inform you that Dr. Chan hopes that this presentation is interactive. So if there are any questions or any thoughts that come across, please don't hesitate to raise your hand, and we'll be able to have you speak. Alternatively, if you put those questions through chat, I'll be able to also present them as well. Again, Dr. Chan, welcome, and we look forward to your presentation. Thank you.
Yeah, thank you so much, Dr. Khalili. So I'm really honored to be here with everybody today. So again, my name is Keith Chan. So please feel free to call me Keith. I'm a professor over at Hunter College. And so today I'll be talking to you about translating research findings to lay populations. I know a bunch of you already, I think from the P30 Community Engagement Network. So it's always nice to see familiar faces. And like I said, we're a small enough group that if you have any questions, feel free to pose them, and I'll try to get to them as quickly as I can. So, and also Dr. Khalili and I think Rochelle is helping us out. So just to moderate. Okay, so I'm going to start by sharing my screen. All right, can everybody see my screen?
Looks great.
Okay, great, awesome. So, so today I'll be talking a little bit about why translating research to lay populations is important. I think from most of us, I think we inherently know that already. But I wanted to at least give some background as to part of the reason why I put together this webinar in the first place was really to actually work with some of our community advisory board members. And so what I'll be presenting today will be 3 examples of research studies that I've done personally. And 2 of them I've published. One I'm currently in the middle of doing. And then also to really kind of outline some questions that one can pose to lay populations. And then also just want to make sure that we highlight some things from community perspectives. And certainly maybe you guys can chime in also as to what are some of the things that you've encountered and ways that you've been able to engage with populations when you're trying to translate your findings to the populations that you're serving. So, okay. All right. So, and I'm going to allot some time for Q&A. So as a background, why does it matter, right? It's important for diverse populations to understand that science, medicine, and overall health can advance for all, and that also populations with health disparities are underrepresented in research and clinical trials, which might actually make such disparities worse. So a lot of it is really about engagement and sharing our findings, but also, you know, getting people to understand kind of what we're doing. So a few things about the background on this presentation. So I'm a co-investigator on the NIMHD-funded Center for Asian Health Promotion and Excellence, as well as the NIA-funded center also focus on Asian Americans with a focus on Alzheimer's and dementias. So part of what we had to do, and I would imagine this is the case for all of us here, is that we had to form these community advisory boards. So these were boards with of people who might have lived experience, who might be community partners, who really kind of understand the work that we're doing. So oftentimes, you know, I find that initially, right, when we put together these center grants, a lot of times it's about like, you know, having this community advisory board to help with recruitment on a lot of projects, which is very important. But part of it is also about disseminating findings, right? So people can understand what we're doing and how we can actually make a difference with the populations that we serve. And so part of the process was that we have scientists who do presentations to community advisory board members. And during this process, what we found was that sometimes the science that's being communicated, the scientists, I mean, they're really focused on really engaging in very high level science. So sometimes the, you know, presentation and the findings were very much more for a scientific audience, like for example, at a research or scientific conference. And so sometimes it was just not necessarily something that always the lay populations were able to necessarily appreciate. And at times they weren't sure exactly how to give feedback. And so what we realized was that, you know, is there a way that we tap into the expertise and the strengths of the community advisory board members so that this could be something that's useful for them, but also in a way that engages with them and helps them to feel valued, but also that would in fact improve the research that we were actually doing. So a lot of it really came out of that work when we started asking, you know, over at CAHPE as well as RCASIA, how can we better engage CAB members in this process? So I wanted to present a few examples. The first example is the research that I've done on a measurement study. So this was done on the Children of Immigrants longitudinal study. I do a lot of research on immigrants. So this was a study that was really unique in the sense that it really included children with at least one foreign-born parent or child born abroad, but brought to the US at an early age. And so the sample included roughly about 5,000 folks in wave 1, 4,000 and change in wave 2, a little less than 4,000 in wave 3. And within that particular data set, there were 215 Vietnamese and Vietnamese Americans, as well as 566 Cuban and Cuban Americans. So why did I choose those groups in particular? Because these two were primarily refugee populations who came to the US under refugee status, but also initially had experienced a lot of welcoming because for the most part, they were fleeing communism, right? So they were welcomed into the US, at least for the initial waves, right? And we also, in those of us who do acculturation research, you've probably seen work that kind of highlights that acculturation processes can be bifurcated, where for some, they kind of assimilate to successful outcomes, whereas others, it seems like there's this segmented assimilation, right? Where folks may not necessarily assimilate to the best outcomes and can lead to actually worse outcomes over generations. So I wanted to focus on these two populations because they had kind of a shared immigration circumstance, but also very different origins. And also there were different racial groups too. So I wanted to do some analysis looking at that. So what I decided to do was to use the Rosenberg scale. This measures self-esteem. There were 10 items. It's a widely used scale for adolescents to look at self-esteem. So what I did was a confirmatory factor analysis model where essentially I wanted to compare what was happening in terms of the factor loadings and also just in terms of what some of how these items lined up based on the Cuban and also the Vietnamese population. So I want to just quickly show you the findings, but essentially what I found was that self-esteem was expressed differently for immigrant youth. Cuban youth have more established Cuban, I think partly has to do with immigration pathways and history, because at the time when the data set was collected, it was right around the 2000-ish time. And Cuban youths have a more established Cuban American identity at the time because they've been in the US for a little bit longer, which may also explain why the scale works better for that particular population. Feeling that they do things as well or have things they are proud of captures both positive self-esteem similarly for both groups. Wishing they respect themselves more and thinking they're no good captures negative self-esteem similarly for both groups as well. Now, I also really wondered if this was tied to somehow to the immigrant experience. So the statement, "I take a positive attitude towards myself," worked really well for Cuban youth, but not Vietnamese youth. The question generally works well for youth who grew up in the US. Are there reasons in the Asian culture that might explain this? The statement, "I certainly feel useless at times, and at times I think I'm no good," seemed not to work very well and had an overlapping meaning for Vietnamese youth. Why would this be the case? Is there a way we can reword them so they can work better? So these were the examples I kind of wanted to pose because those are questions from this measurement study, which I think CAHPE members, lay populations, people who have cultural expertise in the population can answer very well. In fact, when I posed these questions, they had a lot of conversations about, why do they think this is? Part of it has to do with, cultural understandings of the South. There's a sense of humility that's embedded within Asian culture. Sometimes there are also, different ways that people communicate. And so there were a lot of things that came out of a conversation like that. Any comments, by the way? I know I'm kind of going through this really quickly. I'm going to stop sharing for a second. I saw that there were some things in the chat. Oh, okay, they were just welcomes. All right. Any questions or comments before I continue? If not, maybe I'll just keep moving. Okay, so the second example I wanted to share with you. I see something in the chat maybe. Please continue. Okay, so the second example I wanted to share with you was a study that I published, I want to say about 3 or 4 years ago. And this was more of an epidemiological study. And in this case, I used the 2016 Center for Economic Opportunity data, which was a subset of the American Community Survey, based primarily in New York City. So the sample included a lot of older adults, right? Close to 6,000. What I had was essentially, roughly speaking, about 4,000 Chinese, close to 1,000 South Asian, about 500 Filipino, about 62 Japanese, 382 Korean, and also 86 Vietnamese. The results were total population estimates represents, roughly speaking, about 170,000 Asian older adults from the close to 20 million Asian Americans living in New York City. So I did a bunch of things in this analysis. I used stratified survey weights in Stata 15. I used hierarchical multivariate logistic regression analysis. And then I also included other demographic variables such as gender, age, being a college graduate, marital status, residence in different boroughs. For those of you who've been to New York City, we have 5 boroughs, right? Manhattan, Brooklyn, Bronx, Queens, Staten Island. And also being, foreign-born status, English-speaking ability were also included as covariates in the analysis. So some of the results I just want to share really quickly. Among Asian older adults, 23.7 reported living in poverty compared to 18% of the full sample of older adults in New York City. Highest rates of poverty were among Koreans, followed by Vietnamese, Chinese, South Asian, Filipino, and then Japanese. About 12% of Asian older adults reported having a disability compared to 18.5% of the full sample of New York City residents 50 and older. So among Asian older adults living in poverty, 14% reported having a disability compared to 11.9% who did not. A few other highlights, highest rates of disability were among Filipino, South Asian, and then Chinese and Korean. Vietnamese and particularly Japanese older adults had lower rates of disability. Highest concentrations of older adults who were 75 and older were among Chinese, followed by Korean, Filipino, South Asian, Japanese, and Vietnamese. Chinese older adults primarily lived in Brooklyn. I don't know if folks know that, and also in Queens. A lot of Chinese folks don't necessarily live in Manhattan, Chinatown anymore, partly because, people want to own a home. A lot of folks bought homes in Brooklyn and Queens, and also there's places to park, and there's also a growth of Chinatowns actually in Brooklyn and Queens as well, which for those of you from New York City or have been to New York City, you probably have been to some of those Chinatowns in Queens and Brooklyn.
Steve, how did you categorize poverty?
Oh, so that was from the data set. So it was 2 times the level of poverty as measured by the ACS, the American Community Survey. Did I answer your question, Edwin?
No, I was just, it came up in the chat.
Oh, yes.
And similarly, there's a question about disability.
Oh, and disability, that was measured using the Washington Group Measure of Disability. This is the same scale of disability that you would see in, say, the US Census, births data, the American Community Survey, where there were 6 questions, yes and no questions. Do you have difficulty seeing? Do you have difficulty hearing? Do you have difficulty dressing or bathing? Do you have difficulty going out? Do you have difficulty going out and running errands? Do you have difficulty thinking or remembering? So answering yes to any of those 6 questions would essentially be defined as having a disability, at least in that data set. And certainly in most population health research, that's the definition of disability that we see. I know that there are many definitions of disability out there, but in terms of most population health data, that's the metric that's used. Does that answer your question?
Yes, it sure does.
Yeah, it's very similar to the
Thank you.
births data. Yeah, it comes from the same place, really. Yeah, I mean, as a social worker, we think of disability differently, right? Based on the Americans with Disabilities Act, which is more about protecting against discrimination. Also, right, when I work with my clients and we apply for benefits, then that's a very different definition based on the Social Security Administration. And that's probably the most challenging definition, right? Because for those of us who've applied for benefits for clients like SSI or SSDI, over 50% of applications are denied. So, but in this case, the definition I'm working with is really the one based on the Washington Group Measure, which is one that you would see in a lot of different population health data sets. Any other questions before I continue? Oh, yeah. Oh, someone put this up there. Oh, thank you. Yeah. Okay, so a few other things. South Asians tended to live in Queens and in Brooklyn. Similarly, Filipino older adults lived in Queens and also in Brooklyn. Japanese older adults in the sample lived primarily in Manhattan and some in Queens. But just to let you know, within the data set, we didn't have a lot of Japanese older adults. Korean older adults predominantly lived in Queens overall, right? For those of us who've been to Flushing, Queens, you know what I'm talking about, K-Town. I mean, some of the best food in the world, Korean food in the world. I mean, it's right in Flushing, K-Town. I mean, honestly, you can find all of it. Probably even better than Seoul from some of my Korean American friends who told me about it. I mean, I'm not kidding, right? What else? Vietnamese older adults tend to live in Queens and Brooklyn. But then also something to note, more Vietnamese in the sample lived in the Bronx compared to other ethnic groups. So a few other things, Japanese older adults lived in neighborhoods with the highest percentage of persons who speak English well or very well, followed by South Asian, Filipino, Vietnamese, Chinese, and Korean. On average, Japanese older adults lived in neighborhoods with the highest average incomes, followed by South Asian, Chinese, Korean, Filipino, and Vietnamese. Among Asian older adults, more Chinese and Koreans lived in neighborhoods with highest percentage of persons in poverty, followed by Vietnamese, Filipino, South Asian, and Japanese. Koreans and Filipinos lived in the neighborhood with the highest percentage of foreign-born, followed by Chinese, Vietnamese, South Asian, and Japanese. Korean older adults lived in neighborhoods with the highest percentage of persons of Asian descent, followed by Chinese, South Asian, Filipino, Vietnamese, and Japanese. Chinese older adults. So here, there's some nuance here. The first one is just about all Pan-Asians, right? The second one here, Chinese older adults lived in neighborhoods with the highest percentage of persons of their own ethnicity. So in this case, I'm really talking about like ethnic enclaves, like Chinatowns, right? Followed by Koreans, South Asians, Filipino, Japanese, and Vietnamese. So, so some things I just wanted to show based on maps. This is actually just from the
Keith, I'm
neighborhood.
so sorry. There's also an additional question about
Okay.
what was the strategy for sampling?
Oh, so the sampling was using stratified survey weights. So the same successive differencing replicate weights that were used in the ACS data, the American Community Survey.
Thank you.
Sure, yeah. So, okay, so let's see. Okay, here we are. So I just want to show you a few things. Like this is really just from Neighborhood Atlas. Maybe some of you, I'm sure many of you are already familiar because there's a lot of tools out there now that actually breaks down neighborhood disparities. And so this is, so I was curious because I'm doing, essentially hierarchical analysis, mixed modeling, right, to look at neighborhood effects. So I wanted to see what the maps actually say when I look at New York City, right? So here's New York City, Chinatown. Around Chinatown, you'll kind of see like that on the east side, there's still a lot of red areas that still have a lot of poverty disparities. Whereas on the west side, for the most part, it's primarily gentrified, right? And this was from 2019. I think it's become even more so since then. Yeah, and that kind of reflects certain patterns that we see overall in the city. So Chinatown is actually split right in the middle, right? And so these are some of the multi-level logistic regression model results. But let me just quickly go into the discussion of the results themselves. So poverty was not significantly associated with disability when controlling for all other variables in analysis. Now, this is for Asian older adults only. South Asians have 58% higher odds of having a disability despite having lower poverty compared to Chinese older adults. Older age was associated with disability, not surprising, right? The older you were, the more likely you would be disabled. Neighborhood level effects were observed for Chinese older adults only. So I actually was kind of expecting that maybe there would be neighborhood level effects for Koreans because of such a large or large enough Korean population of folks who actually live in K-Town, right, in Queens. So living in a neighborhood with a higher percentage of ethnic specific persons was protective against disability for Chinese older adults only. So some things I think is, I'm still trying to figure this out sometimes. But neighborhood level differences help to explain the variance in disability for Asian older adults. Living in Queens and Brooklyn was initially associated with lower odds for disability, but once controlling for tract level variance, the borough level effect was no longer significant. That's not surprising because each borough is so huge, right? I mean, Brooklyn is a huge place. My parents live in Brooklyn, but it's a huge place, right? Living in ethnic enclaves was protective against disability for Chinese older adults. But so these are the lay questions I came up with that I started asking. What are some neighborhood supports that might explain this, right? This is not something I can figure out from the data alone, but this is something that community partners and people who are cultural experts, they can give me some answers, right? Maybe it's because there's a lot of social service agencies there, or maybe there's a sense of neighborhood unity that's tied to how people have lived there for a certain period of time. So those are things that were also very interesting. So living in an ethnic enclave was not protective against disability for other ethnic groups such as Korean, Filipino, and South Asians. Is there a reason why this might be the case? What can we do to encourage community level supports for these populations, right? So as a social worker, and also as a health disparities scholar, my interest is really finding ways to make people's lives better. So, and those are the kind of questions I think a lot of community members can really answer, right? Or at least point me to the right place. I have some thoughts about why I think this is the case also, by the way. I think there are protective networks within Korean populations. But what I've also noticed is that if you look at, patterns in terms of where people live, what's interesting is that I think for a lot of Korean, not all, but for a lot of Korean American families, especially in New York City, there's a lot of supports from the Korean churches. And the churches, if you map them out on the New York City subway map, they all are within walking distance of the 7 train, all the way from Midtown heading all the way out to Flushing. So, which I thought was really interesting.
Edwin,
Keith,
you have-
I had a question. So there, I'm thinking in terms of just the presence of a disability, and being in a community enclave. I'm thinking that maybe there's a slight disconnect there. It's kind of like if you have a disability, it would kind of be like unmet disability related need. Like,
Yes.
I could see the protective element of having a supportive community, et cetera. May not change the instance of disability, especially if it's age-related things, but unmet need arising out of the disability might be something that's more salient. Do you have ways of potentially looking at that like unmet disability-related need?
So, I think it all kind of ties into the measurement question as well, right? About how disability is measured. That was really kind of one of the earlier questions too. And the way that, the Washington group measures are designed is it is really about unmet need. Do you have difficulty, right? Do you have difficulty with this? Do you have difficulty with these things? So theoretically, if someone has enough resources to actually account for those difficulties, then they wouldn't have any difficulties at all, right? But that's also I guess, when we examine kind of social models of disability, what are the resources within the environment, within one's network that can actually help to compensate for those things? And also just like whether there are assistive devices that people are using or choosing to use or not.
Yeah. Because like if I have a walker, it doesn't mean I don't have trouble.
Right.
I don't have trouble walking anymore.
Right. But it's a perception, right? I mean, I wear, one of those like knee braces when I go exercise on my exercise bike. Otherwise, I'm experiencing a little bit of pain, but I am using it and it's fine, right? And so it really kind of depends on what people are using and how willing they are to use it, and some of it is based on perception. So I think a lot of those questions would probably require really delving into the community and doing some qualitative research in order to really understand how people understand disability, whether they're reporting it, and what are some of the supports that are available to them in different places.
That makes sense.
Yeah.
Keith, I have another question. Just listening to this, in the sometimes among the Asian communities, when we conduct these questionnaires about quality of life or symptoms with respect to chronic diseases, we have different types of reporting, and I'll share with you that as an example, within the context of chronic hepatitis B infection, which is something that we see being prevalent in the Asian communities. We've noticed that individuals that are of Chinese background, for example, report symptoms that are less than what the general population would be reporting with respect to chronic conditions. So something about, cultural aspects may be important with not that they may not be experiencing the symptoms, but the reporting may be not the same. So oftentimes their quality of life is better than what we would have expected. What are your thoughts on that?
So a lot of these measures, right? I mean, it's been a real, area of interest for me in terms of how we culturally adapt measurements. And overall, what we find is that a lot of these measurements may not always work as well with certain populations. And I would say that that's certainly the case for Asian American populations. So sometimes it's hard to be able to make certain comparisons, right? Within, how one compares one to the other. So I think there's challenges, right? Because based on the numbers alone, one can interpret it in one of two ways, right? One, right, for example, your Hep B example, right? Maybe they do in fact experience fewer symptoms, right? Maybe they're managing it somehow. Maybe they're doing it in terms of supports and diet, or maybe they're just not reporting those symptoms, right? Because they're less likely to report some of these things, or maybe if they were to report them, they would verbalize it differently. You know, I teach a social work research class, and we actually just did a whole unit looking at, say, the Kessler psychological distress scale, and how a lot of the questions may not necessarily be understood to be the same, right? You know, even questions like I feel depressed, or you know, or in the BDI, like I feel blue, you know. And by the way, I don't think anybody ever says I feel blue anymore. I don't think that's something that people say normally, regardless of anybody, right? And I mean, I think, you know, as a Gen Xer, I would say I feel crappy, you know, or something. If I were to ask my Gen Alpha nephew, he might say I feel mid, or maybe he'll say I feel skibidi. I don't really know. I don't really know how Gen Alpha. So I don't really know. So, but I think there's different ways that people are kind of expressing themselves. And that's very much the case when it comes to Asian American populations, because we're talking about both language and perception, right? Cultural ways of expression. So, you know, it's a challenging thing, right? I think it's possible to develop measurements that can capture something that's meaningful. But I think, you know, anytime we, you know, use some of these subjective measures to compare across groups, you know, there are challenges. I mean, that's simply, you know, I think the case. I know that a lot of us probably here are starting to think about using objective measures, right? Like saliva tests, and then, you know, other things that might measure cortisol level. You know, there's a lot of things that people are doing. Some of us may even be doing like MRIs with some of our samples. So, you know, of course, some of the stuff is very expensive too. So it really kind of depends on what resources you have, right?
Absolutely. I do recognize your comparison populations are different Asian groups. So within that cohort, you're seeing specific differences in certain populations. So very important questions to be asking individuals about what happens with support or other community level support that's needed.
Right. Yeah. And, you know, and some of this too is also about, you know, and those would actually be really good questions about, like, you know, are people really thinking about the disabilities in the way that I think other people are thinking about the disabilities? There was a paper I published a little while back that looked at how Asian populations, especially Asian adults who report having a disability, even reporting a disability, were less likely to use an assistive device. And that was an analysis I completed doing the Burford data. And I think some of it has to do with the stigma of disability. Maybe people are underreporting it. There may be other things too. I'm not sure exactly.
Very interesting. Rhonda?
Yes, hi. I can't turn my camera on because I have my tech person over here. But anyway, I wanted to make a comment about
Sorry,
it.
Rhonda, would you introduce yourself as to
Oh, I'm so sorry. I'm Rhonda Daly. I am from the Achieve Greater study in Detroit, Michigan. So, and we're part of the HEAN cohort as well. So, and I've been working with Keith on a project, and we just got our slides in. So, kudos for that. But one of the things I wanted to ask or maybe make a comment about is the disability question. So I just finished a project with our Disabilities Institute we have here at Wayne State University, and they've been working with local health departments. And we asked the question, do you consider yourself having a disability? And also ask the BRFSS questions. And believe it or not, people who say that they're disabled may or don't say that they're not disabled, meaning they don't identify as having a disability. They answer yes to a lot of the questions. So there was like it was not congruent at all, and it could be the stigma surrounding disability. But I was very interested in seeing so many people deciding to check off that yes box here. I'm wondering if that same nuance would have been for this cohort if that question was asked, do you consider yourself having a disability? That would have been a little bit more interesting, but I do think that the questions, the way they're asked now and how people answer it, that really does show that people are really being truthful about, their, struggles with, certain things, which is fine. But this also leads to, what are the resources around? And do they need these resources? Maybe some more questions would about those things would have been helpful for this survey. But I do understand this is more so of a secondary analysis that you were doing, right, Keith? So
Right.
yeah. Mm-hmm.
Yeah, so this was the ACS data. So this was the American Community Survey data. So
Mm-hmm.
essentially it was a secondary data source. But generally speaking, whenever those public use data sets would also include a question, are you disabled? Yes, no. There were fewer people, so to your point, Rhonda, there were few people who answered yes to that question, while they might answer yes to the other questions. Do you have difficulty with, these different things, right? Dimensions of disability, or at least functional limitations. So I think, it's so loaded, right? The word disability, and the thing too is that I've had clients who I helped to apply for disability benefits, right? And they were denied. But clearly they have these issues, but because they had that determination letter saying that they don't have the disability, they feel like they can't say they have a disability anymore.
Right.
Until, of course, they get the letter saying, okay, we recognize you have a disability. Then they felt like they could say it. But it's measured using a very different set of constructs, right? When we're
Yes.
talking about public benefits, it's really a cost control construct where they're really, like, the government is intentionally trying to deny as many people as they can, because they don't want to keep paying them. That's really what's going on, right?
Yes.
Whereas if we look at, say, the ADA definition, the American with Disabilities Act definition, it's very inclusive. It's if you consider yourself being part of a group who essentially was at one point discriminated against because of a disability, then essentially you should be protected, right? So the example would be someone who might have identifies very strongly with the deaf community, but maybe they got a cochlear implant and they can functionally hear, but they still very much identify as part of the deaf community. So,
Yes.
and that also, the ADA would protect them, but they wouldn't answer yes, though, necessarily to the questions on the Washington group measures, right? Nor would they necessarily qualify for SSI or SSDI, but they would feel very strongly that they're part of this disability community. So so there's a lot of different ways that we can understand disability.
Thanks for looking into that. And by the way, this measurement, we really don't know what our numbers are for the disabled population at all. And that is why we did that study. I mean, it's very hard. It's not measured much. And, you have these American community surveys and, these national surveys, but what about at the doctor's office, at the local health department? Where are numbers coming from? And that is why we asked those questions, because we needed to know. Right? You can't do
Yeah,
anything unless something is measured, right?
definitely. We need that evidence, right? So
Absolutely. Thank you, Keith.
thank you, Rhonda. Okay, so maybe I'll move on and present the third example. This example I really enjoy talking about. This is more of an intervention, and this is something I'm doing right now. It was recently funded as a pilot award for the P30 Center, and so I'm really excited about doing it, and there's a lot of people who are interested in doing it. So it's called Golden Tea. It's a mindfulness intervention. It was something that actually came out of some of the work that I was doing with community advisory board members as part of CAHPE, the center I belong to, where there was an agency that's been doing this for a while, Hamilton-Madison House. And they were implementing this program called Golden Tea. It's a 7-week culturally based mindfulness intervention. And it's a collaborative project that I'm doing right now with CAHPE and also with Hamilton-Madison House and Tea Arts and Culture. So the goal of the program is pretty simple. It's creating the space and time to slow down with intention, to cultivate connections. And there's mindful appreciation through multisensory guided experiences to engage with nature, art, and each other. And a lot of it is also through a multicultural and multi-generational lens to facilitate story sharing and compassionate listening. So the goal is really to enrich learning experiences, nurture the lifelong learning needs for the well-being of the aging community. And so far, this is based on some of the preliminary research that I've been doing. Since spring of 2024, we had 2 iterations of the T program. And so some of our initial findings are very promising in suggesting better overall mental health and also sense of connectedness with others. And I think what we also are finding, at least with some of the preliminary data, is that we'll need more data really to determine whether there's a delay in cognitive decline, which was something that we were looking for as part of this intervention. So these were some of the example questions that, with interventions, right, it's very easy. I think it's comparatively easy to come up with questions that are relevant for lay populations. So one of the first ones that I actually really wanted to look at was, we wanted to be careful and then asking about memory and thinking. What are some important questions to ask? Or maybe are there tasks we can ask someone to perform that are culturally appropriate, that we can kind of capture a sense of, say, cognition, right? The metric that I had designed or wanted to use was the MOCA, right? Which did involve a number of different tasks, but and it's been translated and there's a validated version for the Chinese population. But, I really wanted to kind of dive into it as to whether, are we asking the right questions when we're looking at cognition? We also wanted to get a sense of connectedness to one's culture. What are important things to consider when working with an Asian population? And then finally, are there suggestions that you may have to further encourage participants to share their cultural experiences that can help reduce loneliness? Because that was really part of the goal, is that we wanted to work with this population. We wanted them to engage. We wanted them to be a part of the community, but we wanted to implement an intervention that could work. But we also wanted to make sure we asked the right questions too. So these are some examples that I came up with for this particular type of intervention. Yeah, that's it. That's what I have. So I left some time for Q&A in case anybody has any questions.
Wonderful. Thank you so much for that outstanding presentation, Keith. Let's open this up for questions. Lots of clapping going on. Thank you again. Okay, Kimberly, go ahead. Please introduce yourself as well.
Hi, everyone. My name's Kim Kester, and I'm based at UCSF and am a close colleague of Edwin Charlebois and Rochelle Blanco and many others who are on this call. Keith, thank you so much. I mean, the title of the talk today was just, I canceled the meeting so I could come to this because I think it is so important. So my question, I want to ask, let me just pull it up so I don't ramble. Going back to the title of this talk, it's about translating research for lay populations. And it seems to me that the way it is that you're translating research is by posing these kind of critical questions, questions that are kind of easily grasped, but, hard to know unless you ask the right people, right? And so it seems to me like what you're suggesting is that the translation happens by going back to the community and posing questions that really only they can answer. So I want to kind of check my assumption there about whether you think that is that really what you're trying to tell us. And then I just have some like kind of practical questions about like, well, before you pose these questions, what are you bringing to the lay populations, to your CAB or advisors? So what is it that you're bringing in terms of results and in what format are they? So just kind of the nuts and bolts maybe of how do you even get to asking these questions, because I presume you have to set the context of what you've learned. Thank you.
Sure, yeah, thanks for that question, Kimberly. I think you're definitely on point there. Presenting things that are easy to grasp, right, but hard to know. Answers that are really important for the research, but are really kind of taps into the inherent strengths and the cultural knowledge of the population, because that's really a way for them to feel valued, that they're offering feedback that's important, and also it's useful to us, right, as researchers. So in terms of the presentation of research findings, the second part of your question, what I try to tend to do is I would take a presentation that I would normally present to a scientific population. I wouldn't necessarily change like in terms of like the tables and all the things that I present, but I would just go through them really quickly, you know, and then I would kind of get cut to the meat of it, the discussion, so that they can kind of get the takeaway. But also what I found too is that sometimes there are people in the community who actually have high level scientific knowledge and they want to see the results. So, but that's part of the reason why I keep the results in the slides, because in case someone asks, I want to be able to show them. But otherwise, I would really kind of take, you know, present really what are the key takeaways, right? So in the first study, I was really trying to figure out like, how can we ask self-esteem questions better for Vietnamese populations, right? That was kind of what I wanted to do all along. That's why I did it, if I were to sum it up in one word or one sentence. The second study, I wanted to see, like, does living in an ethnic enclave, does it lead to better health outcomes for different groups of Asian older adults? That was really my question, right? And then here I have some results that say, well, kind of, you know, it seems to be the case with Chinese, but not other groups. Why is that the case, right? What am I missing here, you know? So it really kind of goes back to like, why did I even do the first study in the first place, right? I wanted to ask that question. I mean, behind all the science, if you strip all the science and the numbers and the stats and everything else, I mean, that's what I'm trying to do. I think that's what we all want to do.
Just to say again, thank you. You're so thoughtful. Thank you. And what I'm hearing from you is that, well, I mean, it's your social work, your beautiful social work background, Keith, right? It seems like this is what I'm stepping away from this is that you're in dialogue. You know, you're a researcher and you're going to ask your questions and you're going to go about it in a way that's highly systematic and can be very distancing and alienating from community members when we are overly academic. But at the heart of it, it sounds like you just want to be in dialogue with community so that your work, which is hopefully going to inform and improve their lives, but it's got to be in dialogue with the community, I guess is my aha moment here from you. And again, something probably everyone here wants to do as well. But thank you so much.
Yeah, thank you. Thank you for your feedback too. And yeah, I mean, ultimately, I think that's what we want to do, right? We want to make life better. I mean, I've been thinking about this too. I have tenure, you know, I've gotten the opportunity to do things now. I just want to be useful. I want to be useful to the people I'm working with, you know.
Thank you so much, Keith, for sharing that actually really important work. Any other questions from the group? Okay. Well, if not, once again, I wanted to thank you.
I'm so sorry because I if other people don't have questions,
go ahead. Go ahead.
Yeah, I have a question from a colleague who could not be here. She is wondering, sorry, how do we actually go about, she wanted to know how to learn what different lay populations need. So it's not so much about translating the research we have, although it could be, but trying to understand what is it about the research that might be important to the population, that maybe it's an analysis that we haven't done, but how do we engage in that kind of conversation to uncover what is important to the lay population vis-a-vis the research that's maybe already been done or research that needs to be done?
Mm-hmm. Right. Yeah, I think, you know, so that's very interesting because, you know, when we first formed the CAHPE, the Community Advisory Board, as part of the center, I think like all of us, right? We, wrote the Senate grant and we put it together, and we thought that, we did what we thought NIH wanted, which was, they wanted us to create a CAHPE so they can get feedback for recruitment and dissemination. But then, I think another piece of it too is that community engagement is a process, right? Where a lot of it is about building trust, and then also understanding the priorities of the people we're serving who are in the community. So some of it may not necessarily be outlined perfectly in the language of, say, the centers that we're part of, right? In terms of some of the efforts that we're making. But one of the things that I felt that we did, really successfully, but it was really a learning process in terms of the Center for Asian Health Promotion and Equity. I'm sorry, Excellence. We changed our name recently too. Is that we wanted to listen to the priorities of the people who are working with us, and what were the things that were really impacting them in the communities, what they were talking about. And that really became kind of a bonding moment for us with our community advisory board members. And then also trying to figure out like, okay, well, what would they want us to do about it? And so we really try to harness that a little bit in terms of talking to people about some of the things that were important. We actually published a recent article as part of the American Journal of Public Health. I know a bunch of us as part of the P30 centers. So the piece that came from our center was really how we took some of that feedback and then we produced these policy briefs based on the priorities of the center, community advisory board members. And they focused on culturally tailored services and also unmet mental health needs of the Asian population. So part of it is that we were thinking, we wanted to amplify people's voices. We want them to get something out of it. A part of it too was also it came from the experience that I had, and also another person who's a co-investigator, Dr. Emerson Aya. We were both part of the Health and Aging Policy Fellows program. And so we both got a chance to work in policy areas. He did his placement with ACL, and also I think part of it was also with CDC. I did my placement. I'm still doing my placement. I'm still a fellow with the House Ways and Means Democrats. So it was actually a really useful experience in terms of learning how some of this stuff actually works. And that at times, when we're looking for people who can advocate for a certain, come to hearings, right? It's very easy to find folks like us because we're academics and we put all our stuff out there. And we love to talk. And so it's a lot harder to find community members who are willing to, who actually have that cultural expertise, who can really tap into the stories and narratives that are happening on the ground, right? So that's really kind of what got me thinking, like, how can we amplify those voices in the communities so that when it comes time for us to find someone or anyone, working, say, at the legislative level, at federal or state, if they need to find an expert, someone who from the community who can share those narratives, like, can we find someone, here, we're trying to put it out there. So this is the person, these are the people you can reach out to, find ways of amplifying those voices. So I think sometimes it also means aligning oneself with the interests of the community. And I'm so glad we did it because it's led to so many different opportunities and good work that's out there. Like the Golden Tea program, it really came out of some of the conversations I was having with the CAM members. One in particular who was talking about, we do actually have these interventions out there to address the needs of Asian older, mental health for Asian older adults, Chinese. We're doing it in our agency. We wish someone would actually do the science. And I'm like, hey, I'm someone. Let me go and do it. I can help you out. And that's how it came about. So I think, yeah. So I mean, I don't know if that really answered your question, but I think a lot of it is about building those real, like, meaningful connections. So
yeah, amazing. I love that Golden Tea intervention. It sounds brilliant.
Yeah, thank you. I think so too. I'm not the one who came up with it, but I'm happy and I'm honored to be the one doing the research right now and the PI on it. So yeah.
Well, thank you. Any other questions, comments? Okay, well, we're almost at the top of the hour. Once again, thank you so much, Shan, for that outstanding presentation and getting us thinking quite a bit. And really, really appreciate all the work that's being done as well. Thank you for moving the field forward.
Yeah, thank you so much for having me. I hope you guys have a good week and enjoy Halloween.
Thank you.
Thanks, Keith.
Bye-bye.
Take care. Bye.